Hello everyone. In the next few minutes, I will focus on the optimal extent of surgery in thyroid cancer. Before start, I'd like to briefly acknowledge the rules of thyroid surgery. Theodore Coyer was the first to systematically observe the long-term consequences of the extent of thyroid resection on patients' quality of life. Based on his follow-up of patients over time, he recognized that total thyroidectomy could lead to severe symptoms than lobectomy cases decades before hormone replacement therapy became available. This leads to modern understanding of balancing surgical radicality with patient outcomes. In the current surgical knowledge, the decision on the extent of surgery in thyroid cancer is mainly based on two topics. The first is the oncological outcome, and the second is quality of life. Let's now look at trends in thyroid cancer incidence. This figure from Lancet that published in this year shows a sharp increase in thyroid cancer diagnosis in the United States over the last few decades. We know that while incidence rose dramatically, rates of metastasis and mortality remained relatively stable. This year-based database from the National Cancer Institute provides a clear picture. In 2024, over 44,000 new thyroid cancer cases are expected in the United States, accounting for 2.2% of all new cancers. However, the estimated number of deaths is only around 2,000, just 0.4% of all cancer deaths. Most importantly, the 5-year relative survival rate is 98.4%. This is the paradox: high incidence, excellent prognosis, and relatively low mortality. And the question is, are we overtreating a disease that often behave indolently? We observed the same pattern in Korea, which experienced what was described as a thyroid cancer epidemic. As shown here, incidence, especially papillary thyroid cancer, rose dramatically while mortality remained flat. We note that widespread screening led to overdiagnosis. And more recent data from China, Japan, South Korea confirm the same trend. In China, a similar trend rise in thyroid cancer incidence is observed, particularly among women in recent years. Japan also shows a steady increase in the incidence over time, especially among women. In Korea, the increase is striking in both men and women. Here we see the Globocan. Globocan data clearly show that thyroid cancer incidence peaked much higher in Korea, especially among women, compared to the United States. This global study from Lancet analyzed thyroid cancer incidence trends by histological subtype across 25 countries. And as we see, the blue line is papillary cancer. Across all regions, papillary thyroid cancer appears to be the main driver of the global rise in thyroid cancer incidence. Despite the global rise in the thyroid cancer incidence, there has been a noticeable shift toward less extensive surgery. Lobectomy rates have more than doubled over the past decade. And as we see, the same study shows also a decreasing trend in the likelihood of performing total thyroidectomy over time, especially after 2050. Here is our university data. In Istanbul University, the trend is the same. Lobectomy case shifts toward up to 30% from 5% in 10 years. Probably this pandemic period bias in the data. In COVID-19 pandemic, the patients did not want the completion thyroidectomy as a possibility of second operation, so the lobectomy rising trend fall down in the pandemic. So, how do we decide on surgical extent? Oncological outcomes in papillary thyroid cancer are primarily influenced by tumor-related factors such as size, extracellular extension, lymph nodes, and distant metastases as well as histological and molecular characteristics. In addition to our tumor biology, patient-related factors such as age and gender also significantly influence oncological outcome in papillary thyroid cancer. And treatment-related factors include extent of surgery, radioactive iodine, TSH suppression, lymph node dissection, and follow-up strategies also play a crucial role in determining long-term oncological outcomes. We classify patients into lower and high risk group based on both survival and recurrence predictors. This risk stratification is crucial and as it directly guides the extent of surgery we choose for each patient. In patients with lower risk features, such as small, unifocal tumors without gross extratidal extension, lobectomy is usually sufficient and oncologically safe. And in contrast, patients with high risk features such as large tumors, gross extratidal extension, or nodal metastasis typically require total thyroidectomy combined with lymph node dissection for optimal disease control. This systematic meta-analysis published in 2020 investigates how the extent of surgery impacts long-term outcomes in patients with low-risk differentiated thyroid cancer. These analyses show no significant difference in the recurrence rate between lobectomy and total thyroidectomy patients with low-risk differentiated thyroid cancer. Similarly, disease-free survival was not significantly different between lobectomy and total thyroidectomy in this group. And finally, overall survival was also comparable between lobectomy and total thyroidectomy in patients with low-risk thyroid cancer. Now let's take a look at the long-term oncological outcomes in patients with high-risk features. This is a single-center retrospective analysis from Japan, published in World Journal of Surgery in 2023. High-risk patients selected after excluding low and intermediate risk cases in 20-year data. Among the cohort, 509 patients were classified as high risk, and after excluding patients with distant metastases and non-curative surgeries, 368 high-risk patients were included for final analysis, and as we see, 56.2% underwent lobectomy and 33.8% underwent total thyroidectomy. Among the lobectomy group, 17 patients underwent completion total thyroidectomy afterward. In high-risk PTC patients, overall survival was similar between lobectomy and total thyroidectomy group. Disease-free survival was also comparable between lobectomy and total thyroidectomy in high-risk patients. Despite this retrospective study, this study provides long-term data on showing comparable oncological outcomes between lobectomy and total thyroidectomy in high risk, highlighting the need for further validation through randomized controlled trials. And several studies have examined the relationship between the extent of thyroidectomy and health-related quality of life, but the results have been mixed. Mongers et al. Reported that while health-related quality of life did not differ between total thyroidectomy and lobectomy, patients who underwent lobectomy experienced greater anxiety regarding recurrence. In contrast, Young et al. Found no significant quality of life difference between total thyroidectomy and lobectomy group. Nicol et al. Reported that patients who underwent total thyroidectomy had more frequent complaints regarding heart rate, quality of life. And Chan et al. Observed that while total thyroidectomy patients experience more anxiety in the first 3 months postoperatively, this difference disappeared after 6 months. Regardless of these variations, lobectomy does not appear to have a detrimental impact on heart-related quality of life. Additionally, Mackey et al. Found that patients with low postoperative thyroid hormone levels experience more severe fatigue. And when we look at the approach of current guidelines, according to the 2015 ATA, the choice between lobectomy and total thyroidectomy should be individualized based on tumor characteristics, risk stratification, and patient-related factors. In the new update of the Korean Thyroid Association guidelines offers a clear distinction based on tumor size ranging from lobectomy for smaller tumors or total thyroid for larger tumors or with extrathyroidal extension. This is the revised 2024 clinical guideline of the Japanese Association of Endocrine Surgery. It divides the high-risk categories with surgical decision based on age, tumor size, and risk stratification. For younger patients with high risk, total thyroidectomy is recommended, while older patients with poor risk might undergo lobectomy. 2025 NCCN details the decision-making criteria for surgical treatment, indicating that total thyroidectomy is recommended in the presence of distant metastasis, extrathyroidal extension, lymph node involvement, poor differentiated histology, or large tumor. For patients without these features and a tumor size between 1 to 4 cm, lobectomy is preferred. And when we see the indications for completion thyroidectomy, according to the NCCN guideline, it was large tumors bigger than 4 cm, gross positive resection margins, gross extrathyroidal extension, confirmed contralateral disease, vascular invasion, and confirmed nodal metastasis. And here is a systematic current review and meta-analysis on the trends and rates of completion thyroidectomy. As we see in the meta-analysis, the most common indication for completion thyroidectomy was pathological findings, followed by adherence of ATA guidelines, surgical margin insufficiency, and right treatment. This finding emphasized the importance of pathological evaluation and proper surgical margin assessment in determining the need of completion thyroidectomy. There is a significant downward trend in the rate of completion thyroidectomy over time as we see in thyroidectomy rates before. And so it was more complicated. This study explores whether completion thyroidectomy increased the risk of complications. And clinical hypoparathyroidism was 2.5-fold more likely for total thyroidectomy than for completion thyroidectomy at 40 days and remained 3.7-fold higher in the long term. We can conclude from this study that completion thyroidectomy does not pose a higher risk of complications. And as we conclude, there is no global consensus in the surgical treatment in thyroid cancer. A personalized surgical approach is essential, tailoring the procedure based on the patient's risk profile, lobectomy for low-risk cases, and total thyroidectomy for high-risk cases, ensuring an optimal balance between oncological control and the quality of life. We hope to see you in AsAES Izmir in May 2025. and thank you.